Good evening, everyone. Welcome to the CSRS Education Society's webinar on technologies in the cervical spine. Our new platform is making surgery safer and more efficient. We'd like to thank all the participants for attending this very informative and interesting webinar. Our speakers tonight will be Dr. Michael McCarthy, Dr. Venu Nimani, and Dr. Shiraz Qureshi. We'll be moderating Dr. Samuel Cho and myself, Dr. Sanjeev Sarotwal. As part of the CSRS, we'd like to encourage you to save the date for our next annual meeting, the 53rd annual meeting and 30th instructional course in Washington, D.C. This year will be held from December 3rd to the 6th at the Westin, Washington, D.C. downtown. We look forward to seeing many of you there. And for those who are not members of the CSRS, we encourage you to apply for membership. Membership applications are open from May 1st to September 15, 2025. And you can look online for further instructions. You can also connect with the CSRS on our social media platforms on LinkedIn, Instagram, X, and Facebook. Tonight's talk will be recorded and be available for future viewing under the webinars section of the CSRS YouTube channel. We also have cadaveric technique videos as well as topical presentations. We encourage you to look up the CSRS YouTube channel for further talks. For tonight's presentation, we will have the three different speakers talk about the various topics here, and we'll have a live discussion at the end, which we find very informative. So without further ado, we'll get started. The first topic today will be Navigation of the Cervical Spine by Dr. Michael McCarthy, MD, MPH. He is assistant professor at Indiana University and part of the Indiana Spine Group. Go ahead, Dr. McCarthy.
Thank you, Sanjeev. I appreciate it. So I'm Mike McCarthy, and so I'm really excited to kick this off. I think this is a really cool webinar, and so we'll be starting off with navigation in the cervical spine. So here are my disclosures. We'll be talking about a variety of different navigation platforms tonight, so I don't think any of these disclosures have any significant bearings on the talk. But I'm kind of a big believer in navigation, and probably the biggest disclosure that I have to give is just the regional trend of navigation and where I work. There's more O-arms, I feel like, in the state of Indiana than there are anywhere else in the country. But I think that the utilization of that is really very clearly evident when you use navigation, whether that's the placement of screws, the reduction in radiation, that real-time feedback and confirmation of placement, that streamlining and taking some of that decision fatigue that we all feel in the OR kind of out of the equation. And then let alone some of the complex anatomy situations when you're really trying to worry about fixation and how do you really kind of accurately and efficiently place screws. Something I think is really important, especially for the younger surgeons, is what navigation can kind of give to you as a tool. I think when you get out in practice, you're trying to match partners who are 20, almost sometimes even 30 years into practice, and there's an experience quotient that's really difficult to achieve. And I think navigation can really help out some of those younger surgeons as they navigate some of the early issues of practice, especially with placing instrumentation. So what is navigation? Well, this was really adopted from a lot of intracranial uses, and this was a Sentinel paper by Nolte in 1995, where he talked about that transition of navigation from intracranial applications to the spine. And just for those folks in the audience who don't really use a lot of navigation, aren't very well versed with it, you can see some of the basic points or parts of of navigation here. You can see on the far left the dynamic reference array. The next picture on the right is image acquisition system, and again, there's multiple systems. There's your optic camera that captures the instruments, which you can see on the far right with the fiduciaries, and then correlate that with the reference array. So for those of us in the audience who are pretty well versed with navigation, this is just a smattering of my cases. It goes all the way from MIS T-lifts, which on the far left, to my open cases on the far right, where I think navigation has a role and again, I think can be really, really helpful. But what about in the cervical spine? Does that, maybe that comfort you have in the thoracolumbar spine using nav, does that readily transfer in the cervical spine? And I think so, and I think it really shines a lot in a variety of different applications, but even more so specifically in those complex anatomy situations, really when we think about the OC to C2 kind of region of the upper cervical spine. Think of that aberrant V3 segment. You think those small lateral masses. You think the pedicles, high riding vertebral arteries, all those things that make that allow navigation to shine, but make fixation of the cervical spine difficult. I know in Indiana, you can see that far right-hand corner. Some of our patients, it can be difficult to really obtain good APM lateral fluoroscopy. So just getting a good shot to try to get a cervical pedicle in can be tough, and navigation can help mitigate some of those issues. Less dissection, I think, is another added benefit. I don't have to see everything. I don't have to see every ounce of anatomy to accurately place screws. I can save some of that incision and decrease in the overall morbidity. And then I think again that immediate confirmation that what the tactile feel I'm getting when I'm placing screws, I'm also visually confirming that based on navigation. But what are the downfalls? What's the pitfall? Why is it not readily transferable from the thoracolumbar spine into the cervical? The biggest issue we see in the cervical spine is the mobility of each individual vertebral unit. And we have to think that, oh man, if I lock the neck down via Mayfield, I'm going to be good. And that's not necessarily the case, right? There's a lot of play that can happen in the system that can make navigation inaccurate and start to add in errors. You don't have a lot of real estate, and so you have to really think about where you're placing this. And then once your self-retaining retractors are in, that those don't move. You got to really lock it in and then get the spin and get to work fairly quickly. Additionally, navigated instruments, you're doing some midline. You're crossing the midline with these at times, and so there can be collisions with the dynamic reference array. Again, proper planning, I think, can help mitigate these, but these are some of the issues when you really think about its application in the cervical spine. I'm not going to get into too much regarding the actual different platforms because I don't think that's very helpful because most of us in our hospital systems probably have these, but you can see they're ubiquitous across the country and there's a lot of them. So what does the literature say about nav? I think this is pretty clear. These three things tend to shine when you look into safety, when you compare free-handed screws versus navigated screws. I think we all know that the accuracy, the less medial breaches can be clearly seen. The efficiency can help. I think it can actually speed you up in the OR when you learn how to use it. But even more so from an efficiency standpoint, I think it can very much allow you to create more robust construct. You're using larger screws, bigger screws, better purchase. And really the hope is that translates into better fusion rates. But the thing I really hang my hat on when it comes to navigation is very much with the reduction in radiation exposure. And that's radiation to us, to our patients, and to our team. And when you think about the low dose pulse sequences and the amount of millisieverts that we're receiving, it really has a significant impact, and I think the overall radiation exposure throughout our career. So as I think about the advantages, as I alluded to, the radiation exposure, but also just the basics of cervical spine, the pedicle screws. This has a great application in tumors, really wonderful when you have high riding vertebral arteries. You think about the workflow. This is an odontoid screw, and that's what it looks like in my OR when I do bivector C-arms, and it's a busy, really kind of an ugly OR to work in. It's just a lot of stuff. When you can see on the far right, this is what it looks like when you're using navigation. This is me and my fellow. We're working. We have a clear field. We don't have a lot of hardware in and out of the field or blocking our views. A point that I really believe in when it comes to navigation is the teaching component of it. And a lot of people have mixed emotions, but I think there's no better teaching instrument than real-time feedback. And when you have someone placing a free-handed screws and you can say, stop and tell me where you think you are, and they can look at a screen and get that, it really is a wonderful education platform. As I mentioned too, optimizing screw size and trajectory is really an added benefit. But why don't more people use this, right? And I think the biggest issue that people tend to tell me is that it takes too long. It's too much effort to get this. That it's like the Apollo missions trying to get the lunar module landed, right? And I think really that relies on you as the surgeon. You are the leader. And these are the three folks that I rely on for all my navigated cases, my tech on the far left, my industry representative up on the upper right-hand corner, and my CST in the bottom right-hand corner. They know when we need the O-arm, they know when we need to get everything ready and registered as far as instruments. And it's not a giant feat to get this going, let alone actually getting the image. People tell me all the time, man, okay, well, if I even have the workflow, getting the image acquisition system in and out of the OR, it takes too long. It's going to take me 15 or 20 minutes. And I tend not to buy that argument. This is just a case I did last Tuesday. You can see it takes 3 minutes and 51 seconds for that Patient gets sterilely draped for the image acquisition to close, spin, and then the drapes are off, and we're off to instrumenting. So I think really, again, it comes down to the surgeon to be a good leader and to organize their team to utilize this technology. So once you have your spin, what does this look like? So this is a standard setup in my OR. You can see I typically have the self-retaining retractors away from the dynamic reference array, which is typically transfixed to the spinous process, either C3 or C2, depending on what type of case we're doing. But you can see there's a tap on the far left, and on the right, you can see there's a pointer that I'm able to kind of get a good understanding as far as what the anatomy may be. An alternative setup would be an extension off the Mayfield. This is a patient that had already had a previous posterior fusion and needed a revision, so we didn't have much bony fixation. So you can see this is my fellow putting that outrigger device, and on the far right, you can see what that looks like in the OR. Again, another very helpful way to use navigation. Here is the actual workflow. This is placing screws. You can see the tap that's getting placed, and we can advance it. We can size it. That yellow bar is typically my rep showing you the size, whether that's a 3.5, a 4.5, a 5.5 screw. What's the length? Whether it's a 30, 35, or 40 millimeter. So again, exceedingly helpful to real time see that. I thought I'd go through some case examples to give you a better example of where I think NAV shines. So this is one of my patients, a 77-year-old female with right-sided severe occipital cervical pain, pretty classic C1-2 arthritis. She went under kind of a fairly extensive non-operative care, and you can see what her sagittal and coronal images show is just that osseous erosion of the C1-2 joint and how diminutive that C1 lateral mass can be. And again, freehanding that can be a tough day in the OR. So you can see that when you use nav, I clamp on the back of C2, and in the upper right-hand corner, you can see this is real-time placing that C1 screw, and then I can upsize it. I can get all the way up to the front cortex. If I want to go ahead and get bicortical, that's not too big of an issue for me to do. I don't really think twice about it, or I fret and have to take a million different x-rays to see where I am. This lady had a high-riding vertebral artery, so again, I audibled fairly quickly to translaminar screws. You can see how long those are. And just the length of that fixation, the rigidity of really filling that laminar part of it. This is another case, again, just able to pull audibles in the OR because you have this real-time visualization of the anatomy. Again, another fairly diminutive C1 lateral mass. I had to place the screw a little bit lower to achieve maximal fixation. I don't know if I would have really done that. If I was under C-arm, I would have probably tried to match the other screw. And again, you can see I did a little mix match of a translaminar and then a C2 pedicle. Just based on her anatomy, I thought that was really the best application of the fixation. Here's a second case I think that, again, really highlights it. This is a 58-year-old gentleman who had a history of a nephrectomy and unfortunately showed up to my clinic with worsening neck pain and had a biopsy-proven renal cell carcinoma, solitary metastasis. And you can see just that osseous erosion that's occurring and thinking about what we're going to need to do to resect this and to treat him. And so here's the MRI cuts, just again showing, man, this goes out really lateral. And unfortunately, as you look through some of these axial views, you'll see that tumor is very much involved in the vertebral artery. And so you got to do a lot of thinking of how am I going to address this? And so preoperatively, we embolized the tumor, but I knew I was going to use NAV, so I asked them to go ahead and place a metal stent through the vertebral artery, not only protect it, but also allow me to work in and around it with my navigated tools. And you can see the spot shot that on the far left, just with the setup. You can see what it looks like when I have the clamp on, and this is before the spin and what we're able to do just from an image acquisition standpoint. And then this is the actual case. You can see this is a close-up of placing those T1 and C7 pedicles, and those are 5.5 25s in C7 and 5.5 30-inch screws or millimeter screws at T1. So again, exceedingly robust fixation because I knew I had to remove a fairly extensive area and I wouldn't have lateral mass fixation on the right. And so I can really, again, use NAV to leverage the type of fixation that I'm achieving and really place exceedingly large screws in there. And again, once those were placed, I needed to move on to resecting the tumor. And again, just from a negative perspective, you can see the C6 nerve root, C5 nerve root that was really getting pushed ventrally. And then I used the pointer to resect. I could see in and around the tumor. I can see how far out laterally I need to be. I can see where the vertebral artery is, and then use the sonopet to really remove as much of the tumor as possible. And you can see this is kind of after the resection, how much I was able to get just from a posterior approach. And then I was able to take them anteriorly and do a corpectomy. Another big added uh, benefit of the 3D rendering, I can get a good sense after everything is played view of what I've achieved from a fixation standpoint and also a tumor resection. And again, here just the finals again showing the corpectomy. So in conclusion, I think this is very much a tool that can make your life easier as a surgeon. But like any technology, we have to remember it's just a tool, right? It doesn't really drive what we do. It just helps us get to that destination. Those basic tenets of why that patient's in our office, the stenosis, the instability, the deformity, those are the key things we have to focus on. And that decompression, stabilization, optimizing alignment are only kind of, we're able to get to those successful outcomes with utilization of NAV. And so again, I think much like a lot of new technologies we're going to talk about tonight, I hope that you can see the application of NAV and its benefit and utilize it. I do have one last slide. This is mostly for our New York audience, and go Pacers.
And next will be by Dr. Vanu Namani from Washington State, and he'll be giving us a talk on augmented reality, 3D printed guides, and related technologies.
All right. As someone who's also from the great state of Indiana, I will also say go Pacers. So yeah, hopefully they turn up. So great introduction to navigation by Dr. McCarthy. So I'm going to talk to you about some of the newer kinds of navigation systems that have come available over the last several years, and some that are maybe a little bit less utilized. And I just want to thank the CSRS for giving me the opportunity to talk about this with you all. So these are my disclosures. I do do some consulting for Mighty Oak Medical, which is one of the makers of 3D guides, as well as for Orthofix, which makes one of the light-based navigation systems that I'm going to talk about tonight. And then a couple disclaimers. I do typically still prefer freehand technique for the vast majority of instrumentation placement in the cervical and upper thoracic spine. And this is for some of the reasons that Dr. McCarthy talked about, which I'll also get into a little bit later. And then all of my posterior cervical fusions, I still do open. And so my experience I'll talk about here is really as it pertains to open surgery and not related to any sort of MIS fixation of the posterior cervical spine, which I, as of yet, do not do. So as Dr. McCarthy talked about, why might we use navigation in the cervical spine? This is just a schematic. When we think about the typical types of fixation that we often utilize in the cervical spine, especially in the subaxial cervical spine, these are often lateral mass screws, and these are quite safe screws to place by a freehand technique because we're going medial to lateral, and we're kind of aiming away from danger, right? We're aiming away from the spinal cord, we're aiming away from the vertebral arteries. However, with more advanced types of fixation techniques, such as using subaxial cervical pedicle screws, which we may want to utilize for certain situations, these can be somewhat difficult. They're often small and cortical, and there is danger both medially and laterally with the vertebral artery laterally and spinal cord and nerve roots medially. Other reasons why we might want to use navigation is from distorted anatomy, either from prior surgery or from spinal deformity. And then, as Dr. McCarthy had brought up, it might decrease the stress in surgery because it can simplify to some extent the placement of instrumentation in otherwise challenging anatomic situations, as well as I also agree that for training residents and fellows, the real-time feedback is really fantastic. However, motion can cause navigation errors, and there is the potential for time loss and workflow disruption to using navigation. Now, depending on the situation, the net benefit of using navigation might be helpful. However, in other situations, the net benefit might not favor navigation, and you might want to use freehand technique depending on the resources and efficiency with using freehand technique. And I think the more complex the operation, obviously, the more important it is to get through the case efficiently. And so this was a C2 to pelvis that I did, where the navigation tools we were planning to use all did not work. This included a mix of 3D printed guides and stealth, and we had some errors due to registration because of loss of normal anatomic landmarks. And so we ended up using all freehand technique for this case, which enabled us to get through it and have a good result. So the modalities I'm going to talk to you about tonight are light-based navigation and registration, 3D printed guides, which is a technology that's been utilized a fair bit in the thoracolumbar spine, but is a little bit newer in the cervical spine, as well as some augmented reality tools that also can be useful for navigation. So first we'll talk about light-based registration and navigation. So this allows the registration of spinal anatomy using a visual light spectrum camera that basically takes a photograph of the spine in the operating room. And this analyzes the surface topography and then syncs this data to a preoperative CT scan to essentially localize the spinal anatomy and allow you to perform navigation. The benefit of this technology is that it uses segmental registration. And so, as Dr. McCarthy pointed out in his talk, one of the issues in the cervical spine is that it's quite mobile. And so without segmental registration, you can certainly have navigation errors in a flexible cervical spine. The other benefit of a technology like this is that you can actually move the array without having to perform a re-registration because, again, you're just taking a picture in the operating room. And so this allows quick movement of a reference array if necessary. If it's being blocked by the path of your instruments, all you need to do is just move the array and take another picture, and then you're ready to go again. And this also relies not on an intraoperative spin, but rather a preoperative CT scan. And so there is no imaging acquisition that's required in the operating room. And so there is a time savings in that manner. Just a case example of this, this is an 81-year-old woman that came into our hospital with central cord syndrome and acute neck pain after a fall. And she had an autofusion from C5 to C7, fairly severe stenosis from C2 to C4, as well as a C1 ring fracture. And so this is an example where we use light-based navigation to perform this operation. And so we were placing C1, C2, and C5 fixation. And you can see here the registration data that you get. Each of those green dots in the image is an individual pixel that is synced between the picture that's taken in the operating room and the CT scan that was obtained preoperatively. And then these are some of the images from the navigation itself. The nice thing is that even though C1 is in two pieces, you can separately register those and actually place fixation quite readily. Same thing with C2, where there are relatively close high-riding vertebral arteries, and we place subaxial cervical pedicle screws at C5, and you can see the tracks that we created there. And so this is the final intraoperative construct with C1 lateral mass screws, C2 pars / pedicle screws, and C5 subaxial pedicle screws. We obtained a postoperative CT on her, and so you can see the accurate placement of all the instrumentation. And I've marked the location of danger in red there, the vertebral arteries. You can see that we are able to place, using this type of navigation, screws into tight spots with a great deal of accuracy. There are some limitations to this technology. So you do need a preoperative high resolution fine cut CT. This just does not work as well with an intraoperative scan, although it can be done, but the fidelity is just not quite as good as a real CT scan. Additionally, the landmarks for light-based registration can be obscured by blood and scar tissue. And so this can affect the quality of the image that you obtain and how well it actually syncs to your anatomy. And there are no large series as of yet describing the accuracy of this technology in the cervical spine, although there have been some case reports published. Another technology which can be useful is the use of 3D printed guides. This is something that I think less people are familiar with. And what these are is essentially a CT scan that is turned into a three-dimensional model of the spine. And then using that 3D model, you can generate 3D printed guides that directly fit on the posterior elements of the spine with drill channels that essentially can be utilized to create a predetermined drill tract into the pedicle or another bony channel in the spine to assist with placement of instrumentation. So these are both patient-specific and level-specific, and this is an example of a plan that's generated for a particular patient. And the nice thing is that there is little to no change in a typical open surgery workflow. There's no need for an intraoperative spin. There's no reference arrays or any of those things. And you can see there's no C-arm in there either, right? And so all it is the guide that is placed down on the prepared posterior spine. This is a use, me with my fellow doing a scoliosis case. And so it's quite nice from that standpoint. And these are available from several different companies, and there are also surgeons around the world that are self-printing these as well for use. You can see there are a few thoracolumbar deformities in there, as well as a cervical model down at the bottom. We did a study of this looking at our experience. We've used this for over 6 years now for thoracolumbar reconstruction. And so we did a study looking at our experience of placing over 2,000 screws in adult spinal deformity reconstruction cases. And these were all thoracolumbar cases. And we found a 99.5% accuracy rate assessed by postoperative CT scan with 0 spinal cord injuries or vascular injuries. And so this is definitely safe in the thoracolumbar spine. A recent study by one of the Italian groups did look at this in the cervical spine with patient-specific 3D printed guides, and they found a 93% accuracy rate for placement of cervical pedicle screws. Importantly, the breaches, the majority of them were lateral, which is obviously concerning in terms of risk for a vascular injury with injury to the vertebral artery. However, there were no neurovascular injuries in this series that they reported. The limitations of the guides are that the guides can be bulky depending on their design and can be difficult to seat perfectly on the spine, especially in large patients with deep wounds. And there may be additional time that's necessary for dissection to completely clear off the soft tissue so that the guide can have a very solid fit on the posterior elements of the spine. Last technology I'm going to talk about is augmented reality. And so this is something that was developed to address the issue with navigation of the fact that typically when we're using navigation, we are staring at a screen or an external monitor rather than looking down towards the patient. And augmented reality systems allow for what I call a heads down display, where the navigation info is projected onto or near the operative field via either goggles or a headset, so that the navigation information that you're utilizing is projected in a place which is also where you're looking down at the patient. And so the nice thing about this is that you're not having to look up. There's an ergonomic benefit to it, and there's a melding of the information that you get both from the tactile and visual feedback of the actual patient's anatomy. And this is true both in open and MIS surgery, although it does shine a little bit more in MIS surgery in its current iteration, but allows you to meld the open bony anatomic landmarks that you see from open surgery, as well as the more detailed axial and sagittal information that you get from navigation. In MIS cases, there's also a virtual 3D model that can be visualized under skin, which makes it feel like you're doing open surgery, but in an MIS setting. And this also can be helpful. As I mentioned at the beginning, I've not done this in the cervical spine via MIS fixation techniques, but I have done it frequently in the thoracic and lumbar spine. And the tactile feedback helps with merging that with the 3D model visualization. There's very little data on the use of this in the cervical spine as from a data standpoint, and so this is still in a nascent technology. I want to finish up by showing a case, and this is actually a case that resulted in a complication with use of navigation, which is why I want to show it. This is a 64-year-old gentleman with a prior ACDF 10 years ago from C5 to C7. He initially did well, but then developed severe neck pain and subsidence, which was treated in a collar. And his current symptoms are neck pain, dysphagia, and difficulty holding his head up with recurrent myelopathy. The zoomed in images of the cervical spine shows multi-level subsidence with fracture of C5, C6, and C7, with the plate essentially completely dislodged from the anterior cervical spine. MRI shows stenosis with some tenting of the spinal cord over the apex of that kyphosis, and you can again see that plate essentially dislodged from the cervical spine on the sagittal CT scan. There were several challenges with this patient. He was quite a large patient with a very short neck. This is a revision surgical approach as he had prior surgery. He had high riding vertebral arteries bilaterally at C2. I wanted robust fixation, again, given the kyphosis and multi-level fractures and failure that this patient had previously and given his size. And so from a surgical plan standpoint, we plan to do a posterior fusion from C2 to T2 using instrumentation placed using 3D printed guides to place multiple short subaxial pedicle screws, given the second stage plan of a multi-level corpectomy. So we did not want our screws to extend into the body. And then removal of those ACDF cages and reconstruction in the front. This is the surgical plan that we got from for placing our screws using 3D printed guides. Intraoperatively, the posterior wound was quite deep as well as stiff, and so this made accurate guide fit difficult and unreliable. You can see the depth of that guide is essentially completely buried within the wound. And so we actually abandoned this intraoperatively, and we switched to using augmented reality-based navigation for the placement of screws. In this case, I used a 2 mm burr to cannulate the pedicles, given that there's very little deflection of the anatomy using a burr rather than a drill or a gear shift, because anytime you're pushing with navigation, you're moving the anatomy, and what you see on the navigation screen is no longer a reliable representation of where the anatomy is. And the nice thing is a 2 mm burr is not much bigger than the end of a ball tip probe, so you can cannulate quite small pedicles with this. And then you can always complete the cannulation if necessary using an awl or a tap. For augmented reality and alternative workflows, actually have only your assistant wear the headset. So you can see here, I'm actually not wearing the headset. I'm looking at the screen, and my assistant is wearing the headset. So I can easily see the open anatomy using my loops and my regular light visualization, while my assistant has line of sight onto the reference array. So there's no line of sight issues. This case was going well. We placed left side of pedicle screws from C3 to C7, but during cannulation of the left C2 pedicle with a high riding vert where we were trying to get a long screw in, I injured the left vertebral artery. I consulted one of my neurovascular colleagues and I completed the posterior portion of the case, placed a short screw, and we actually did an intraoperative angiogram, which showed a small pseudoaneurysm, which ultimately later, 4 months down the line, underwent flow diverting stent placement. He was neurologically normal. And so in this case, I think one of the limitations that happened was my reference array was on T1, perhaps too far away from C2 for navigation to continue to be accurate. And so this is something to be aware of with a mobile cervical spine. I think also one of the limitations of navigation in general is there's a tendency to trust the nav inherently, just like you would trust Google Maps if you're getting directions to a place you don't know, but you ignore the detour signs telling you to go elsewhere. So I think you always need to be aware of the tactile and visual feedback you're getting from the anatomy and trust that as well, in addition to using your navigation as a guide. So in summary, there's a lot of new technology available to help us perform cervical spine surgery safely, but you need to know the limitations of each technology and when to bail, and build in redundancies when trying new things. This is us using cervical pedicle screw guides for the first time, and also using stealth navigation to confirm our landmarks and tracks when trying new technology and techniques. Thank you.
Now that we have the Indiana representation, I'd pivot to the New York representation, have Dr. Shiraz Qureshi from HSS, co-chief of HSS Spine, talk about utilization of robotics in the cervical spine.
Thanks so much, and thanks for having me. And yeah, I will do my best to represent New York. I feel like I'm already doing this in protest with, I didn't realize I had 2 Pacers fans. So I've been tasked to talk about robotics in the cervical spine, and I'll do my best. I'm certainly passionate and involved deeply with robotics, but the field is quite young with regards to applications in the cervical spine, but hopefully this will leave people on the call thinking about what the options are. So most significant disclosure here is that I am a consultant and get royalties for Globus for their robotics platform. And I'm going to be talking a little bit about robotics in general, but specifically the Globus robot. So, throughout at least my career, there's been a rapid expansion and now adoption of enabling technologies in the operating room. And if we think about where innovation in the last 10 years has come, it's less about the widgets and more about how we do things more accurately, more precisely, and more efficiently. And that can be seen with the utilization of technology in the operating room. So I think this webinar specifically really useful for at least if there's young surgeons on the call who are thinking about sort of what's next. When we think about robotics, you really can't think about it without navigation. And I think all too often I hear people using navigation and robotics as if they're synonyms, and they're completely complementary, but not the same. And I would say the early iterations of robotic technology that I used, I wasn't ready to adopt, specifically because it was married to fluoroscopy as opposed to navigation. And I would say that the reason that robotics now in the current generation has been so successful with regards to widespread adoption has been specifically because of its marriage with navigation. But ultimately, similar to what you heard in Dr. McCarthy's talk, traditional fluoroscopy results in significant radiation exposure and can lead to less screw accuracy. And that's what really has necessitated the evolution of newer technologies, especially for those of us who have adopted minimally invasive and percutaneous techniques. Navigation, as you've already heard about, and I won't spend a lot of time on, is really in concept no different in the operating room than it is, when we're driving our car, with one major difference, and that is that there isn't real-time updates. And that's really, really critical when we're thinking about spine surgery, that we're working on a fixed picture, but the anatomy is changing at every moment. And this is especially important to remember when we're thinking about the cervical spine, where there's increased mobility between vertebral segments. And when we're using, whether it's robotics with navigation or navigation alone, you have to be able to understand what's happening in real time. So I am confident that with our industry partners, we're going to be able to solve this problem, but we certainly aren't there yet. I think, Mike touched on this, but certainly the use of navigation has led to radiation reduction and has been shown to be able to be used without adding significant time demand, and results in improved screw placement, especially with percutaneous screws. And in the cervical spine specifically, with regards to navigation, I think from a learning curve perspective, start using these enabling technologies in uninstrumented cases can be incredibly helpful when you're thinking about workflow and setup. And this case example of a patient with a C7T1 herniated disc, a case that I think is a great way to address this, is a single level posterior cervical foraminotomy discectomy. And that can be difficult with regards to localization with traditional fluoroscopy, but with navigation, you can really get easy access, great visualization, and be really targeted. And these are the stepping stone technologies that lead to the advancement of things. And that's where robotics comes in as the next iteration, using navigation as the basic platform, and then adding the control of a robotic arm. So in my opinion, what are the advantages? Why should we be thinking about adopting robotics, and why are so many people adopting robotics? It has to come with a reduction in radiation exposure greater than what we're already seeing with navigation. You need to have some improvement in the type of fixation that you're able to place. It should be good for the surgeon. It should allow to address certain surgical pathology that you may not otherwise be comfortable addressing. And you should be able to use it broadly in your surgery and not just for a single step. And then most importantly, it should be able to be used simply by everybody who's using it, and not by just certain experts who are dedicating a lot of time to it. For me, robotics really starts with planning. This can be done the night before surgery or intraoperatively. This is just me planning a case in the operating room, and I like this time, spent with my residents or fellows who are in the operating room with me. We're talking about the different aspects of the case, why we've chosen to do what we're doing, different angles, what we want to think about facet morphology, et cetera. In terms of then placement of instrumentation, again, you can see here you've got the robotic screen, but we're working, the navigation screen, but we're working through the robotic arm. And the robotic arm just allows to set a trajectory. That arm doesn't get tired, but at the end of the day, the surgeon is doing the work. In spine currently, the robotic arm is not entering the patient. I do like that the robotic arm can be used for multiple parts of a procedure. I like using it to hold the tubular retractor, or set different trajectories for things that are sort of inclusive of an entire procedure. And we have found that this does influence, at least in our practice, the length of screws and the size of screws that we're using, which again, regardless of what part of the spine that we're working in, should lead to increased construct stability. And then importantly, the radiation dose we've shown further reduces. And you might look at these numbers and say, well, okay, you go down from 25 seconds to 20 seconds, or from 40 milligray to 38 milligray. But because radiation is a cumulative impact over a lifetime, any amount that you can reduce is going to be a plus in the long run. So why would we think about robotics in the cervical spine? So I think we'd all agree, when we think about fixation in the cervical spine, we're thinking about lateral mass screws or pedicle screws. Lateral mass screws are certainly something that I would imagine everybody on this call is very comfortable with. We think about them as safe with regards to the spinal cord and moderate risk with regards to the vertebral artery. Pedicle screws are more challenging. Obviously they're relatively commonly used at C2 and C7, but in the subaxial cervical spine, there is a significant risk with regards to the spinal cord and the vertebral artery with the placement of pedicle screws. And very importantly, the pedicle morphology can change from patient to patient and even from side to side. So why would we think about it then? Why would we even consider placing a pedicle screw? Well, pedicle screws are clearly stronger than lateral mass fixation. And in general, for majority of cases, lateral mass fixation is adequate. But in a case where you may be dealing either with patient-specific pathology, where there's bone density issues, or if you're trying to save levels in terms of fusion and to shorten a construct but still want significant construct stability, that's where the ability to place cervical pedicle screws can come in very handy. So we, thanks to CSRS and through a research grant, looked at a study, which was a cadaver-based study, to look at accuracy, precision, as well as systematic error with regards to cervical pedicle screw placement using robotic navigation. And what we wanted to do is we wanted to assess all three of these things. We wanted to say, is it accurate? Is there precision? And then if there's error, what is that error? So the rationale for our study was, can robotic technology ultimately be used to accurately place cervical pedicle screws? When we looked at accuracy, precision, and error, we looked at it with regards to, or with consideration of, what the FDA wants robotics to show. But specifically, we wanted to be thoughtful with regards to what the needs are in the cervical spine specifically, to be able to better say that these screws can be placed safely. So we did our analysis in 3 dimensions when we looked at accuracy, precision, and error. We looked at screws with regards to craniocaudal, mediolateral, and anterior posterior position of the screw. And we looked at these areas at 3 different positions of the screw: at the tail, at the mid pedicle, and the tip. Obviously understanding that the most important areas are going to be the mid pedicle and the tip, because that's where the neurovascular structures are most significant. Our hypothesis, we stuck with the accuracy, precision, and systematic error numbers as are required by the FDA for robotics. But you may look at this and say, well, I'm not comfortable with something just within 4 millimeters, especially in the cervical spine, because that's too much error. This was a cadaveric study, like I said. We used 3 cadavers, 30 total screws. We had done a power analysis showing that a minimum of 23 screws placed would be required in order to be able to show statistical significance. We were able to place 30 screws. What we specifically did here was we performed a preoperative CT scan on these cadavers. We then planned the preoperative screw trajectory, and then we transferred that preoperative plan to our robotic platform. This was done open, not percutaneous, so a full dissection of the cadaveric specimens was performed. The heads were stabilized in a prone position or taped, and then we used a spinous process clamp in the upper thoracic spine, and then used robotic navigation in a standard form where we used a drill, a tab, and then ultimately screw placement. We then performed a postoperative CT scan. We had previously validated a model using computer vision to be able to place sort of on 2 different CTs the planned trajectory with an overlay of the trajectory of the actual screw, and then determined accuracy, precision, and error at the three positions that I described earlier. This is the post-operative imaging. You can see all 30 screws were placed. This image essentially shows that overlay using computer vision algorithm, green line being the planned screw, red being the actual screw. And as you can just see here visually, good accuracy with regards to placement of planned versus actual. With regards to the actual accuracy, precision, and systematic error, what we found was with regards to accuracy, you could see that at the mid pedicle and tip, we were at 1 millimeter or sub-millimeter error. With regards to precision, again, at the mid pedicle and tip, we were at sub 2 millimeters. And with regards to systematic error, what we found was that when there was an error, it was that we were a little bit lateral and a little bit low compared to the plan. But again, this was sort of looking at what the likelihood, if you were going to miss, which way the screw may miss. Now, this information in a vacuum is meaningless, so we decided to sort of try to understand what this meant compared to information that we know about using enabling technology in the thoracolumbar spine and also doing placing thoracolumbar screws freehand. And what was very surprising to us was, and again, this is just a single cadaver study, so by no means am I saying that this is absolutely conclusive, but this study suggested that the placement of robotic cervical pedicle screws, at least in these cadavers, was not just as accurate, but actually more accurate than what other studies have suggested as well-placed and safe and accurate and precise freehand navigated and robotic screws in the thoracolumbar spine. Certainly the obvious limitations of a cadaver study, as you could imagine, with regards to spine mobility and not having stability, which would potentially lead to even more error, and obviously just a single study. But what we did realize was while we set out to say, could we place pedicle screws safely, we ultimately said, we can certainly talk about accuracy, but safety is a separate issue. And when we think about sort of the likelihood of breach, what we realized was that the only thing that we could say with regards to safety is that the bigger the pedicle, the less likely that you are to breach the pedicle. But safe with regards to safety, as a surgeon, you have to take everything into account and really understand pedicle size and morphology when you're thinking about safe screw placement. But at least with regards to the plan and then sticking to the plan, we were able to show in this cadaver study that robotics and navigation together can be a powerful way to accurately and precisely place cervical pedicle screws. So in wrapping up here, where do I see robotics making an impact? I think certainly as we work with our industry partners in thinking about posterior instrumentation, especially in the upper cervical spine, C1 lateral mass, C2 pedicle, but also in the subaxial spine. And as we think about not only doing more complex cases, but also as we try to do the simpler cases in less invasive ways. And the good news is that a lot of our industry partners are starting now to make instrumentation handles, both for screw placement and for taps and drills, to accommodate percutaneous placement through a robotic arm. The other thing that I just want to highlight here for CSRS members is, especially the younger members, is that if you look at clinical data on robotic use in cervical spine, I could only find one study. So this was a study looking at 88 cervical pedicle screws. Their conclusion was similar to our conclusion for our cadaver study. But this is a real opportunity for the members of our society to sort of say, hey, you know what, we want to take the lead in this. And for anyone interested in sort of finding a place where the future may be. I think the thought of how to properly use robotics and navigation in the cervical spine certainly is an area that is understudied. Some unique considerations for the cervical spine. I know Mike mentioned most of these, but anytime I'm doing either navigation or thinking about robotics in the cervical spine, patient positioning, where the reference frame is going to go, accuracy. I always do an intra-op CT as opposed to Florida CT merge in these cases, because all of those things are going to matter, and your room for error is essentially, you should think about it as close to zero. There is definitely a learning curve with the cervical robotic navigation that I think is a little less steep than the lumbar spine, meaning that it's a little harder, takes a little longer, and there can be some workflow complexity greater than in the thoracolumbar spine, just with regards to positioning and things of that nature. But ultimately, somebody's got to accept the learning curve. And I think anytime that whether it's robotics or any of the technologies that you've heard about tonight, I think figuring out what works best in an individual's hands. Not all of these technologies are going to be equally translatable to everybody. But the goal of these technologies is that for the majority of users, it starts to level the playing field with regards to the hard skills of placing screws and things like that. The soft skills, like Mike talked about, make all the difference with regards to indications and patient expectation, but let patient outcome be the main driver when it comes to all of this. Thanks so much, and let's go, Nix.
Thank you, Shiraz, and I'd like to thank all three speakers for their outstanding talks on emerging technologies in the cervical spine. Now the session is open for Q&A. If you have any questions, please type it in the chat box, and we'll try to address some of them. And by way of starting, I'm going to ask all three speakers on the topic that they actually had covered, and that is the mobility of the cervical spine. The number one question is, how do you stabilize the cervical spine when you're positioning it? And number two, intra-op, I think Dr. Numani had mentioned he likes to use the burr instead of pushing on the cervical spine because of the mobility issue. How do you deal with that? So how do you immobilize the cervical spine? You use
Sam, I could start there. It's
Yeah.
specific to me, and I'm sure Mike and Venu and others have their own ways, but I, instead of using a Mayfield or Gardner Wells tongs, I'll use a face positioner, similar to what you might think of somebody, a face holder that you might use in the cervical when you're doing a lumbar case. I do find that results in even more stability of the cervical segment than a Mayfield does. And then I am pretty liberal, even if I'm working with navigation or through a robotic arm with the use of fluoroscopy. I think it's a great place where you want to sort of use everything in your armamentarium as far as imaging goes to ensure that you have accuracy. And I haven't yet done robotically placed percutaneous pedicles screw fixation in the cervical spine. Waiting to take the leap on that one, but at least in an open case, I'll still have the C-arm sort of draped in, and then have the face and the neck in a face holder, tape on the head, so that you get as much stability as possible. But even with that, there can be movement. What I find is that setting the trajectory and the starting point sometimes can be of greatest benefit, and then just kind of staying within those angles. But it's something that you need to be cognizant of the entire time.
Yeah, so I also do something similar. I don't use the face pillow, which is a good idea, but I also use a Mayfield. I think for some of the technologies where you have to register to an intraoperative CT scan and then you rely on the frame not moving the entire case, I think it's super important. One of the potential benefits from some of the other technologies that I talked about is there's less of that reliance on not bumping the frame or movement, because you can just re-register very, very quickly. I think also with like 3D printed guides, for example, again, because they're segmentally based and they sit on the posterior elements of a single vertebrae, then there is no chance for shifting. However, one unique thing that can be an issue there is if you position the spine in lordosis, or meaning an extension, like you might in a Mayfield, if you want to just set the alignment before you start, the guide can actually have interference from the adjacent facet joints because they're shingled, or even the adjacent spinous processes. Because the design of the guide is based on their position in a CT scanner, and sometimes you might have the head, with a bump behind it or something like that. So you have to be mindful of that. So there are some nuances from a positioning standpoint that can play a role in this. If I'm using 3D printed guides, I actually usually position the spine in Gardner-Wells tongs in flexion. That way there's less interference from the adjacent anatomy, and then I'll just use bivector traction and then place the spine into extension when I'm dropping my rods and locking in the final alignment.
The way I tend to think about it, Sam, is once that spin occurs, an intraoperative spin, it's kind of like a nuclear isotope. It's going to decay. How rapidly that decay is happening, it's difficult, but I think especially in the cervical spine, you have to be acutely aware of that. So I tend to think that as soon as I capture that, that's the most perfect information I'm going to have. It's all going to slowly become more and more inaccurate. So I will wherever I've clamped, that's again typically C3 or C2, I then go and do my furthest segment away. So if I'm going to instrument T1 or do any cervical pedicle screws, I go furthest away and then work my way back up towards the reference array. Again, always thinking of time and distance as the enemy. So time from spin and then distance from array, right? Those are two things I always kind of beat into the fellow's head, is those are their enemies.
Thank you. Those are very useful answers and very helpful tips as well. Dr. Wilmer from Godoy thanks us for the excellent talk. And there's a question about changing alignment during the case to provide better lordosis.
So
Anyone want to?
yeah, I could start there. I'm sure everybody, I use an old trick that I'll place a IV pressure bag under that same face pillow, and then right before, after all the instrumentation is in, I'll have somebody squeeze the bag, which allows, sort of this improvement or restoration of lordosis. Take an X-ray, see what that looks like, and then place the rods.
Yeah, I use so in a flexible spine, I think that placing the placing the patient's head where you want it, getting an X-ray and making sure you're happy with it, I think works well. For some of the more severe deformities, I will often use Gardner-Wells tongs, or if you have it, a pneumatic Mayfield, where you actually have control of the head through the drapes, and then you can adjust the head position intraoperatively. Although realistically, sometimes it's a little hard unless you have the drape that comes with it. It's hard to grab the handles and actually adjust it. So I'll often have an assistant or one of our PAs or even a resident or fellow get under the table and manually manipulate the Mayfield and the patient's head while you bring the head up with the pneumatic head holder. And so there are some tricks there. The other things that you can do is intraoperatively, if the posterior elements are still intact or the spinous processes are still intact, you can use Atlas cables around the spinous processes. And as you tighten the Atlas cable, that will bring the spinous processes closer together. You can also use a penetrating towel clamp to essentially squeeze on the posterior elements, and that because it's a fair bit posterior from the center of rotation of that individual vertebral segment, that can also generate lordosis as you then tighten your set screws and lock down your rods segment by segment.
Great. Thank you very much. I think it's already 9:01, so this will bring us to the close of this webinar. So this will be uploaded in YouTube. So join the YouTube channel for CSRS, and then look out for the next webinar. Thank you, everyone.